countries, when they sign up to the study, we actually said that there is no funding. And in the contract, they actually agreed to follow every bit of the protocol and sponsor the trials. And I would also like to acknowledge Associate Professor David Wild, who is the Australian PI in this study. So you don't need me to convince you that we're doing better and better in terms of extending lives, not only in Australia or high-income countries, though, but also in the Asia-Pacific region. And indeed, the citation that I'm citing there, published in Annals of Oncology, they are estimating there is 1% of decline in our mortality rates each year, regardless of income level. And in the Asia-Pacific region, it is a huge cancer burden. And how I really see it is I originally came from Hong Kong, and that's around 7 or 8, well, I mean, when I left Hong Kong anyway, there were around 7 million. Now they're probably up to 9 million people. And how I'm really seeing that is that it is really projected to have around 6.5 million of new cancer cases in this region over the next decade each year. So it is a big thing. Every single time when we have all this surveillance and survival data that comes out, it further tells me that disparities certainly occur. And so we certainly know that, and this is a recent paper published in The Lancet from the Concord 3 study, that further affirms, tell us that there are definitely disparities in survival outcomes. But as a supportive care or survivorship care researcher, do we know that the disparities also happen in supportive care outcomes? So what we really wanted to do is to use Australian data as a benchmark and to compare our supportive care outcomes across the Asia-Pacific region. So first of all, we did a survey with cancer survivors, and then we also did another survey with oncology practitioners to look at the attitude, basically whether they think that survivorship care intervention is part of their role. We also asked them about their confidence and the frequency of practice in terms of how often they actually deliver this care to their patients. So we used the WHO translation guidelines, and in the patient survey, we used the CASN. And I was just talking to Professor Butel yesterday, and I still remember the first day when I emailed her and asked her for permission to translate these tools and use this tool for this study. We also asked patients about their physical symptom burden, and we also asked them a single item of quality of life from 0 to 10. With the oncology practitioner study, it is really a tough ask for our collaborators to be going out there and get oncology practitioners to participate, because in Asia, across a number of countries, our cancer patients are treated in general hospitals or in general wards. So it is actually quite a tough ask for them to go out and actually look for oncology practitioners, people who specialize in cancer care, and how we define it to enhance the consistency. We are saying everyone who is caring for cancer, using more than 50% of their work time caring for cancer patients. And how we develop that tool, we actually developed, we construct 29 items according to the IOM report in those 4 domains. And so for each survivorship care intervention or task, we are asking them about whether they feel that it is part of their responsibility, whether how confident they are in a scale to deliver those care, and also how often they deliver those care for cancer survivors. So in the patient cohort, we had 1,873 patients, and as you can see, they're quite a widespread, or sort of, they're all quite spread out across all the countries, and quite spread out as well in diagnostic groups. What I also want to point out, though, was that we actually say that you can recruit anyone who has completed their primary care treatment, and what we got was actually a group of people in the mean time since diagnosis is around 5 years. So with the oncology practitioners as well, that we have got quite a good spread from inexperienced to experienced practitioners. But what I also want to highlight is the distribution between physician and nurses and allied health And interestingly, a lot of my Asian colleagues are still telling us that actually allied health is still not very well regarded in the Asian region, and therefore for you to actually find allied health people who are looking after cancer patients as their main role is actually once again quite a tough ask, and hence that distribution there. But we do have quite a number of physicians and nurses who participate in this study. So my first question is really, are there any similarities and disparities in supportive care outcomes of cancer survivors across this region? If there are similarities, can we start sharing some of our resources and some of the evidence that we produced in our region? And if there are disparities, and how we can actually start prioritizing some of those things. When we look at quality of life outcomes, and once again, it's quite a blunt measure that it is only from 0 to 10, we were trying to make it quite feasible because we have to do quite a large study targeting everyone who's coming to our waiting room in the tertiary cancer setting. And of course, we actually see a difference between Australia and all the other countries, as well as high-income country versus low-income countries. Once again, we actually see a group of people who have very low quality of life. And once again, how do we identify this group and how we can prioritize care for them, and how can some of the risk stratification things that we begin to develop in the Western world apply in this region as well at a later stage when we have more evidence. With regards to symptom concern, they are actually very similar to some of the findings that you have already heard at this conference. But what I want to ask the floor to consider is whether you think that there is a difference in symptom concerns or symptom burden between Australian patients and our neighbour countries. Do you think that there is a difference? I didn't know before I did the study, so there isn't. There actually aren't a lot of differences at all, and we actually do share a lot of the problems in terms of symptom concern. And what I want to highlight to the governments in this region, though, is that you know, and I can put them in terms in way that I hope that some of the policymakers will start to take notice as well, you know, like how some of the presenters have been putting it 2 and 3 patients, or, you know, 3 and 4 patients experience all these issues. And I guess as we know more and more about how we can deal with some of these things a little bit better, I think we're still advancing in our symptom science, but how can we begin to share our resources as well? And these are the symptoms with at least 45% of cancer survivors reporting them. Now, coming to the CHASM, which is the unmet need tool, over the coming few slides, I just wanted to have one point to demonstrate to you when you actually compare the unmet care needs between Australian patients and our neighbouring countries, there are actually quite a bit of difference, and later on I'll show you the multivariable analysis, but just to show you in terms of face value, these are actually the differences. And of course, in some countries, they're telling a little bit more of the story as well that we need to further explore. But similarly, for comprehensive cancer care and information, we're seeing similar trends with Australia being the red line. Our patients are consistently reporting lower levels of unmet care needs. And when we look at quality of life and relationship, similar things have popped up again. These top-ranked unmet supportive care needs in Australia are not new to you, and parking, of course, always come to it, and that's why John absolutely smashed it yesterday. This is what the patient tell us are the most important thing. But what I want to highlight to you, though, is interestingly, as we continue to develop the evidence based on fear of recurrence and how we deal with concerns about cancer coming back, similarly, our patients across the Asia-Pacific region are telling us the same thing. So how can we begin when we start having level 2 and even level 1 evidence on some of these interventions? How can we actually start sharing, and how can we actually start contextualizing some of this evidence to make sure that they are applicable to our neighbor countries as well? And I highlighted those in orange. They are some of the similar unmet care needs when you compare our patients and patients from the other countries. So once again, how can we share? How can we actually begin to take a leadership role in Australia? So this is the multivariable analysis, and I'm always very, very excited when I see p-values like that. But then once again, when you have thousands of patients, that's what you tend to see. But what I want to highlight, though, is that all the other countries consistently have lower levels of unmet care needs compared to Australia. It was very useful for me to find that patients with multiple myeloma and lymphoma have the highest level of unmet care needs, but some of the other things we are also quite, we're expecting to see some of those things anyway, but not receiving chemotherapy and not receiving radiotherapy is also linked to higher level of unmet care needs. So is it because they don't receive that care, that treatment, and therefore they actually miss some of the care provided by the cancer team? I'm not sure, and we certainly need to explore that a little bit further. What can we learn from the oncology practitioners in the region? We actually see a big difference, and this is totally unexpected. I did a nursing survey in Australia asking very similar questions. What we found, we were also we also had some unexpected results. People who work in the regional and rural area consistently reporting higher scores than those working in the metro areas. So is it because that we are actually highly specialized in the metro areas? We have access to pastoral care, fertility counselors and social workers or what have you, and we tend to actually decentralize a lot of the roles. And whereas in actually regional and rural areas, our colleagues seems to be just doing it all and have to be quite competent in them all, we don't know. But these are their perceptions anyway, and I do think that it is a good starting point. And another explanation too is that whether people who are in the lower income countries, whether they actually have a lower expectation on what excellence means or the comprehensiveness of care that is required of our patient. But this formed the baseline, and I think it will be interesting for us to look at the individual country level. Now, I mentioned a little bit yesterday about all of this multidisciplinary professional survey, and I think we do have to be careful because, and as a nurse, I think I can say that a lot of the time nurses are so keen to complete surveys, and we actually, a lot of the time, are quite over-presented in a lot of the surveys, and so making conclusions about these survey results and generalizing it to every health professional is basically not, or every discipline is basically not appropriate. And what we see here is that physicians and nurses see that and you can see people claiming the turf, basically, that, you know, people are saying that these are actually what I feel that I'm actually more responsible for, and these are actually not. And it's interesting to see physicians and nurses and allied health have different perceptions around what their responsibilities are. So understanding these, how can we actually then go back to some of the policymakers and some of the healthcare leaders and begin to strategize a little bit of our interventions. If we are planning to implement some of our evidence or contextualize some of our evidence in this region, who are the people that we should really talk to? And interestingly, physicians are the most confident in delivering all of the tasks. So we definitely need to explore that a little bit further. We ask oncology practitioners about the barriers to quality survivorship care. And I've cut out a number of them, and these are the ones that have come up as the top 5 for Australia and high-income and low-income countries. And once again, we do share some of them. But I always have a problem when people tell me that they have a lack of time, but I actually think that it is really around the priority, how we organize care to actually enable people to receive the care that they deserve. But interestingly, if you look at some of the resources and guidelines resources, I do think that it is time for us to begin to share. And indeed, in Australia, we're so fortunate that we actually have some of the materials in different languages already, and so how we can actually share and contextualize them. So key messages, there are definitely similarities, and for those similar problems that we face, can we actually start sharing? There are also disparities in how we can prioritize care. I'm just going to skip through to the last slide. I do think that in Australia, we need to begin to reflect how fortunate we are. while we keep, we notice and we note all the problems duly experienced by our patients, how can we actually start sharing and how we can actually take a leadership role to translate evidence into practice. We published these two studies, one in Annals Oncology recently and also BMC Cancer for those people who are interested. This is only the beginning. We are going to use a similar methodology to repeat the surveys around palliative care and patients with advanced cancer. But palliative care is not very well established in this region, so what we're going to sell it as is people living with advanced cancer, a new population of survivorship groups. So we are publishing from this data, and there will be more to come. Thank you.